So I'm going to go over the neurological manifestations of COVID-19. And I'll start off with a series here of just coronavirus basics and what's known. I know a lot of people on this will probably know a lot more about coronavirus since the February and March pandemic began here. But basically, the coronavirus is normally found in the avian and mammalian species. It was originally grouped into the family of Coronaviridae based on its appearance. It has that crown-like appearance around it, and that's given by this glycoprotein-studded envelope on electron microscopy. In general, it invades the respiratory tract via the nose, and after about an incubation period of 3 days, it causes the symptoms of a common cold, nasal obstruction, sneezing, runny nose, occasional cough. And in general, that's usually where it ends. In certain people, obviously, and we've known this for the last few months here, it gets very severe, and we've had several 100,000 die at this point. Looking at the coronavirus basics, just kind of looking at it as a virus in itself, it is a positive sense, single-stranded enveloped RNA virus. It falls right in this area. And this envelope is studded with the projecting glycoproteins that everybody knows about. And this is responsible for its attachment to the host cells. It also carries the main antigenic epitopes. And this is where your antibodies can kind of come from. And then under that is this core that consists of the single-strand RNA associated with the nuclear protein. And although mucus and cilia generally clear the airways of the particles, coronavirus actually infects the superficial cells of the ciliated epithelium. So that S protein will allow for the recognition of the target receptor and bind there. What we've recognized over the past few months is that these spike glycoproteins are essential for the viral entry into the ACE2 receptor. And neurologically, this expression of ACE2 receptors are seen in many cell types, including the neurons and glial cells of the brainstem. And this lends to its potential neurotropism. Looking at this, the possibility for neurological complications are there, but from both a direct and indirect neurotropism as a result. This picture kind of gives you a good representation of where all the spike glycoproteins find the ACE2 receptors, but these are the major ones. So the neurotropism of human coronaviruses, this has been suggested for some time. And this is ever since the first coronavirus has actually started to come about. Switching over from mammalian bat species and avian species into human. And we were looking at these back into the early 2000s. This has been seen in both in vitro and in vivo studies, and it showed that certain strains of the viruses could actually persist in the human brain tissue by actually targeting these oligodendrocytic and neuroglial cell lines. And then with some of these diseases, we started to see neurological manifestations such as Bickerstaff's encephalitis overlapping with some Guillain-Barré. We also saw intensive care unit acquired neuropathies, seizures, strokes, ischemic, both as well as hemorrhagic. And this really kind of complicated the clinical course of patients that had any of these coronaviruses. Looking even a little closer into the receptors itself, when you look at the ACE2 in its expression mainly, you can see this in other species. And looking at this in the brain of a mouse, you see very key regions over here, like the subfornical organ, the paraventricular nucleus, all the way going down into the tractus solitari, as well as the dorsal motor nucleus of the vagus. These are all very important structures that deal with the regulation of blood pressure, body fluid homeostasis. Some of it deals with awake and sleep cycles as well. So all of these are affected, and all the way down into the intermediolateral cell column. So dysautonomia could be seen with something that affects the ACE2 receptor in such a way. So all of these started to look at all of these receptors and in all of their locations started to become more of an area of interest, especially for neurologists and neurocritical care people, because these all became more notable in these patients with diseases that progressed further than just the respiratory status. So looking at it, also, so these ACE2 receptors are also in some populations, especially in the cardiorespiratory centers like the brainstem, the raphe nucleus, the hypothalamus, and motor cortex. This actually can play a role in central respiratory failure, maybe also a reason why some of the people are having more trouble getting off ventilators and breathing on their own and taking adequate ventilation. This also may allow the virus to have other neurotropic effects, and this was the feeling there. More recently into, after it hit the United States, mostly in April and into May, we started to realize that the SARS-CoV-2 may actually also gain access into the CNS via the olfactory receptor neurons. And this is why we were figuring some people were experiencing some inability to smell or anosmia. The medullary cardiorespiratory also may play a role in central respiratory failure as a result of this as well. And so we're looking at this and seeing that this SARS-CoV-2 infects both the neurons and the glia, and this can actually cause an inflammatory response leading to a bigger breakdown of the blood-brain barrier. Fast forward a couple of months, and then we start to see our first US neurological manifestation report. So this was one of the first reported cases out of Henry Ford, and patients saw this woman. She came in very similarly with the symptoms of respiratory ailments and stuff, but all of a sudden she started having mental status changes, and they started to see, they got an MRI and they saw this acute necrotizing encephalopathy. And this is usually a rare complication of influenza and other viral infections. It's related to the intracranial cytokine storms. It results in blood-brain barrier breakdown, and this can be with actual viral invasion or just parainfectious demyelination. But the proposed mechanism that the people in this study felt happened was that there was a neurotropic mechanism where the virus may have gone through the cribriform plate and started to go directly into the brainstem here. It's a possibility. Looking at, and I'll get more into this later on in the lecture here, but looking at it further, it may have been more along the lines of other things that happened, and we'll look at that neuropathology later on. But the first retrospective study of COVID-19 neurological manifestations came from the Wuhan, China population. We had about 221 patients at that single center. And this is one of the papers that a lot of people will cite because people saw that 5% of the cases of these patients had ischemic stroke, about 0.5% had a cerebral venous sinus thrombosis, about 0.5% also had intracerebral hemorrhage. And that these ischemic and hemorrhagic strokes, impaired consciousness, and muscle injury were more prevalent in patients with more severe respiratory disease. And this was one of the first reported cases and case series. So fast forward to now. So we're looking at the neuro manifestations, any kind of reported pathologies, manifestations, and theoretical implications going forward from here. So the studies from the current pandemic, they're accumulating, and they're accumulating at an incredible pace, as all of you know. There are increasing reports of COVID-19 patients presenting with dizziness, headaches, myalgias, inability to taste, inability to smell, but there is also some more serious manifestations that people are having, including this polyneuropathy, myositis, cerebrovascular diseases, encephalitis, and encephalopathy. You know, even our population, we're starting to see a lot more GBS than we had seen with other viral diseases. So this is kind of an interesting disease in that it really kind of seems to stimulate all parts of the nervous system. The immune system. There's some discrimination between causal relationship and incidental comorbidity, and this is going to be difficult. This is probably going to be studied out for months, years, before we actually understand what truly was the neurological manifestation of COVID-19 and what was purely just a stroke on its own or some kind of other encephalopathy on its own. Preliminary studies, though, are showing that acute stroke may complicate or coexist with COVID-19, and that preliminary study, like I said before, showed just 5%, 0.5%, and 0.5%. So going into that, what are the main concerning neurological manifestations of COVID-19 that most people are very interested in and kind of wanting to know more about? I broke it down into the acute cerebrovascular diseases, which would be stroke, hemorrhages, and venous sinus thrombosis. Then the acute encephalopathy versus encephalitis, and then looking at the CNS inflammation, both encephalitis and meningitis. Then going into seizures, and then some neuromuscular diseases and other manifestations that people have with this. And looking at it, so with previous coronavirus outbreaks, both SARS-CoV-1 and MERS, et cetera, ischemic stroke was reported with these. And we started to recognize into 2007 and 2010 that a lot of these strokes were direct result of the coronavirus outbreaks at that time. More recently, if you look at COVID and stroke, I did this today just to see how many results would turn up. And it looks like just typing in stroke and COVID, you get about 631 results. This is exponentially higher than what was there even last month. But people are starting to recognize that stroke and COVID are they coincide with each other. And like I said, probably months to years after, we're going to actually get to the full picture of what has happened. But looking at these, most of them are descriptive studies, looking backwards and retrospective, looking backwards at what their patient population has had. Some of the take homes from this are that, and this is highlighted in this New York City population, patients are younger with stroke with this. So like in the case population from New York City, large vessel occlusion was in 5 patients younger than 50, all had lymphopenia. And then they had elevated inflammatory markers on admission. 2 had no symptoms whatsoever of COVID, and they just had strokes in 40s, like they were in the ages of 40s. They also did a systematic review of 39 patients from 6 studies, and that showed that a mean age of 61.4. All of them had some kind of underlying risk factors, but surprisingly, about half of these patients died from this, and that I believe was from a Wuhan cohort as well. So stroke is it's seemingly more. It happens a lot more often with these patients, but it's also happening in younger populations with this. Looking at it, several hypotheses rise for what's causing this increased stroke risk. And this goes back to some of the first coronaviruses causing this. But looking at it, some patients have this hypercoagulable state due to this sepsis-induced coagulopathy. You start to see elevated levels of D-dimer, fibrinogen, CRP, prothrombin time. All of these are kind of causing in the body this hypercoagulable state. There were some case series where patients were put on heparin or low molecular weight heparin, and there's some improvement in the rates of stroke seen in those populations. In addition to that, some antiphospholipid antibodies were also reported in patients with multiple territory strokes. So there's some suggestion that maybe antiphospholipid antibodies, in addition to this, are related to the hypercoagulable state. This also, the virus also seems to bind to this and deplete the ACE2 and the activity through that. And ACE2 really kind of fights against ACE1. And when ACE1 is kind of left unopposed, the thought is that this is leading to more pro-inflammatory state, further worsening of hypertensive state, worsening lung injury, and then worsening autonomic dysregulation. So all of this together increases your stroke risk altogether. Which of these hypotheses, or is it a combination of these hypotheses or something else, is yet to be found. But these are 2 of the leading hypotheses as to why there's such an increase in stroke risk. Looking at it further, severe COVID-19 also shares common risk factors with cerebrovascular diseases. And the majority of stroke services worldwide have been also negatively influenced in terms of care delivery. So a lot of these numbers may be underreported as well, just because a lot of people were staying home and still are staying home instead of going to the hospital. Especially, I would say, in April into May, just looking at our numbers in particular, this was published recently, but just looking at it, stroke and ICH volumes have dropped incredibly in both the COVID-19 and non-COVID-19 populations, and the neurosurgical volumes have dropped off incredibly, and as well as follow-up with neurologists at outpatient volumes. Looking a little bit into the acute intracerebral hemorrhage, a lot of this is thought to be secondary to ischemic stroke and then a secondary bleed from that. But there is also some traction to some of these things, as in the adhesion of the virus to ACE2 causing subsequent dysfunction of blood pressure regulation, hypertension potentially, and then bleed through that. Especially in patients with underlying neurological issues and blood pressure regulation issues to their brain. In severely infected patients, coagulopathy and prolonged prothrombin time also can lead to disseminated intravascular coagulation. This also can cause secondary intracranial hemorrhage. There was a retrospective study. It's probably one of the largest that was done. And only in 2 cases, patients presented with neurological symptoms prior to COVID-19 associated respiratory syndrome. But looking at it, the majority of patients presented with COVID-19 respiratory prior, and what happened was the symptoms were severe in most of these cases. The results of this kind of suggest that there's the presence of ICH may actually occur as a late temporal course of severe disease. But a lot of them actually happen prior to ECMO, which is kind of an interesting thing, because I would have thought that maybe ECMO led to some of these subarachnoid hemorrhages. What they did see in this was they did see several patients with intracerebral hemorrhages, which were parenchymal, but the most frequent presentation of bleed from these patients was an isolated acute cortical subarachnoid that was along convexities. So that's kind of an interesting thing. I was consulted on several patients, obviously, for being critically ill, having COVID, and then having an encephalopathy. One of our patients actually showed up with a brain that looked like this. This is a susceptibility weighted image, and you can see these are all tiny microhemorrhages all throughout the brain. And I thought that this was a fascinating picture to take a look at, especially with looking at some of the neuropathological findings that I'll go over later. In addition to this, there's acute cerebral venous thrombosis that happens, especially intracranially, with this hypercoagulable state. Due to hypercoagulable, they're at higher risk for this. Patients seem to clot more in the arterial phase, however, than the venous phase. As we saw, the 0.5% in this study had the CVT. However, this was far lower than ischemic stroke. So just kind of looking at it, there is hypercoagulability, and patients, both young and old, are, the possibility for cerebral venous thrombosis is there. Looking more into the encephalopathy, CNS inflammation, encephalitis, and meningitis type of picture here. This was first reported actually in Wuhan. And so in early 2020, I think it was published back in January, that was the first patient that had presented with COVID-19 that had developed this decreased consciousness during the hospitalization. They decided to do a lumbar puncture on this patient, and they found that even in the lumbar region, there was a positive PCR for this. Now, caution's kind of highly suggested in this kind of a N of 1 type of thing. The other thing is that it could have been secondary to a traumatic lumbar puncture with contamination of CSF sample or something like that. So that can't be excluded. Looking into more studies, though, there was more convincing evidence presented in a case where there was a meningitis and encephalitis in a comatose patient with a positive PCR in the CSF, in the CSF, and neuroimaging indicative of right lateral ventriculitis and encephalitis mainly in the right mesial lobe and hippocampus. So this is more of that viral type of encephalitis that we would look for in a patient with a positive PCR in the CSF. These are both novel cases in that they have a PCR in the CSF that's positive. Because what we're starting to realize is, and I'll get into this again more in the neuropathological findings, but more often than not, CSF is not showing for PCR positivity, and it's not 100% sure as to whether this is some kind of thing where it doesn't live in the CSF or it binds so quickly to neuronal tissue that we don't find it as quickly. But or perhaps we're doing the wrong PCR for this PCR test for this kind of a virus, although that seems a little bit less likely. Okay, looking at this, an autopsy of 8 patients with confirmed COVID-19 infection actually reported that all of the patients that had the SARS genome were detecting the cytoplasm of the hypothalamus and the cortex neurons. So this is also leading to that, maybe it's not in the CSF necessarily, but maybe more so within the cells of the brain. The low reported rate of CNS infection in patients with COVID-19 is likely an underestimation, as few patients with severe COVID-19 infections have had CSF or brain tissue sampling. Of all the people that have died from this, it's unfortunate in some ways from a medical perspective that we don't have a lot of neuropath staining. The reason for this is that in trying to access the brain, and pathologists will report this, but apparently the cutting of the skull itself to access the brain causes a lot of aerosolization of particulate matter. And so actually getting to the brain and trying to autopsy it becomes a very risky strategy. So a lot of the patients that have this encephalopathy associated with COVID-19, this is more and more realized, this probably as into June, August, and then even into this month. But we're seeing patients that are agitated, confusional, and there's this abnormal cortical tracts signs that are being seen. They're documented initially this was in about 33% of patients, and they had this persistent executive syndrome. More recent studies are now showing that up to maybe 70% of patients actually with severe disease are showing some signs of encephalopathy. When these patients are imaged, and again, prior studies did not have extensive neuroimaging because it was just too much of a risk to take these patients down for MRIs and other studies. Even EEG at that time was very difficult. But among these patients that actually got neuroimaging, there was some leptomeningeal enhancement that was seen, which is suggestive of a viral infection, viral encephalitis. There was some frontotemporal hypoperfusion on perfusion scans, and there was cerebral ischemic stroke in about 3 in this particular study. Looking at it though, CSF wise again, it was performed in 7 of the patients. It was abnormal in 3 of those patients, just showing illegal clonal bands. But it was negative in all of the examined CSF samples, so the PCR as well. So the PCR again is being negative is this ongoing thing. Looking at the encephalopathy itself, it was initially thought to be secondary to the elevated amount of sedation because this was really a respiratory disease primarily. Patients were on very, very high levels of medications, whether that be paralytics and all of the other different sedative agents, Versed, Ativan, propofol, fentanyl. A lot of different, I know certain hospitals were actually running low on some of these sedative agents, and they started to go to phenobarbital and even pentobarbital to try and sedate patients, just to adequately sedate them. Some of the things that we've seen also on EEG, and this is something I guess kind of important to look at, is the burst suppression ratio of some of these patients is near 1, which means that they have almost no cortical brain activity. And some of these patients just need to be paralyzed because no more amount of Precedex or propofol or anything like that is necessary than to take their breathing rate down. And it's a possibility that maybe the SARS-CoV-2 is actually activating some of their breathing responses. So paralytics may be more helpful on some of these patients that have this severe encephalopathy and need to be intubated and on a breathing tube for a long time. Just kind of looking at this a little bit more, delirium is also playing a role, obviously, in COVID-19, and whether that's a strict ICU delirium versus if that's more of a COVID-19 related encephalopathy yet remains to be seen. But the ABCDEF bundle is not being adhered to as solidly as it was, and it is usually with other respiratory diseases and other ICU diseases, mainly because patient contact is risky. But looking at it, patients are dealing with both hyperactive and hypoactive delirium, both where you get agitated, start to have paranoid delusions, and even have hallucinations. Patients are actually presenting with these signs as opposed to develop them over time. And unfortunately, some of these patients are having both hyperactive when they come in and then hypoactive as they're saying through their ICU stay. It's important to recognize these and treat accordingly. What are the other things that we're looking at? So we're going into seizures a little bit as well. Originally, like I was saying earlier, continuous EEG was not completed routinely, especially during the peak of the pandemic. New onset seizures in non-epileptic patients were recently reported. We had actually seen 2 patients with primarily, one had COPD, one had asthma, and they'd been presenting with seizures. Outside of that, then a whole lot of studies started to come about with retrospective series and looking at electrographic patterns in these patients. There were 2 larger studies more recently looking, one with 8-channel EEG and one with 21-channel EEG. But there was a lot of generalized rhythmic activity and generalized periodic discharges. This is usually seen with severe sepsis and septic type populations, but looking at this COVID-19 type of patient population, they fit right in, and they have every chance to have these seizures just like a septic patient. Looking into neuromuscular disease as well, we have seen peripheral nervous system affected pretty severely on some of these patients. A lot of them have ICU myopathy, but then there's severe deficits, axonal involvement, respiratory failure with the subsequent need for mechanical ventilation in several patients. This is also somewhat underreported, I believe, but Guillain-Barré was diagnosed 5 to 10 days after the onset of COVID-19 symptoms in a lot of patients. And this isn't a lot more than with other viral illnesses. So there may be some immunomodulatory type of thing going on here. But looking at it, peripheral nervous involvement has also been documented in 2 patients that were diagnosed with Miller-Fisher syndrome and polyneuritis cranialis at 3 to 5 days after exhibiting COVID-19 related symptoms. And this was very early in some of these out into April. I think we have a case series as well of some of these patients, but it's a very interesting it's a very interesting thing that's happening with this. Looking at it also, we've also seen some cranial nerve palsies. This is a particular case where a patient was negative for herpes simplex, varicella zoster, and SARS-CoV-2 in CSF PCR, but his MRI actually showed contrast enhancement of the left facial nerve right over here in the arrow. And this was, I mean, there's not a real other syndrome or any other inciting factor for this person to have this cranial nerve palsy outside of this. So they reported this case, and that was kind of an interesting thing. Going further into the anosmia and gustatory dysfunctions, a lot of patients started to reveal that they had this inability to smell and this dysfunction of taste. And this was very, very early on in the course of COVID-19. They did a study finally of 417 patients with mild to moderate COVID-19 symptoms. And they found that there was a prevalence of almost 86 to 88%. And there was about a 25% recovery from both symptoms within 2 weeks. So that's actually pretty good. The other thing though is that as a result of this, the WHO and I think the CDC both together started to recognize that anosmia and dysgeusia are both now presenting symptoms of COVID-19. Just going into the neuropathological findings a little bit here. Like I said earlier, neuropath specimens were not originally obtained in COVID-19 patients, really due to the risk of potential aerosolization of viral particulate matter. And so there was a delay in obtaining samples for any kind of review here. CSF samples also, there's this false negative, and we're not sure if this is due to improper analysis of sample or maybe it doesn't live in the CSF. Or maybe it doesn't enter the CSF and it just has direct neuronal activation. But CSF samples have all been pretty much negative outside of some of these single case reports. And then we have false positive as well. And maybe this is contamination of CSF with viral particles due to bleed during that or sampling. It's unknown as to whether also some of these patients were encephalopathic or if they were just trying to obtain CSF on patients that were not encephalopathic. A lot of the neuropath specimens that were obtained were on just patients that had passed away, and they did full body autopsies on them. One study of 10 patients, and this is a post-mortem CSF analysis, actually showed no evidence of viral invasion and no signs of encephalitis and nervous system vasculitis by CSF PCR testing. But again, that study also, all of those patients passed away from respiratory illness, and none of them had any kind of I guess, neurological findings going into the hospital, nor during their hospital stay until they were put under for anesthetic purposes. Another postmortem tissue study of 6 patients actually showed localized perivascular and interstitial encephalitis with neuronal cell loss, axon degeneration in the dorsal motor nuclei of the vagus, cranial nerve 5, nucleus tractus solitari, like all of these areas with high levels of ACE2. So looking at it, you have one study that's showing no viral invasion in a patient population that didn't really have any neurological syndrome. And then another one that's really showing like a lot of different tissues that have had this, that kind of broke apart because of, COVID-19. So it's a little bit in both ways, but I think towards the end of this, we'll probably try and figure this out a little bit more. These were the clinical characteristics of the 6 fatal outcomes that they had in theirs. And in that second study, looking at it, I don't know how large this is showing up on everybody's screen, but everybody did have this elevated C-reactive protein. They had a pretty lengthy stay on the ventilator. They had medical histories of certain different things, but if you look at their GCS and their neurological symptoms upon admission to the ICU, these 3 actually were GCS 15 with no neurological syndrome, and these 3 were somnolent, but they had a GCS of 12 coming in 10. So nothing to write home about, but all of them had these petechial bleedings and lymphocytic findings all throughout the brain. This guy had encephalitis. It looks like all of them had encephalitis, actually. So looking at it, and they all died from different causes. 2 had cerebral hemorrhages. This one had pulmonary artery embolism, cardiorespiratory failure, and the rest of the 3. So just kind of looking at it, it's a mixed picture here, but a lot of patients in this particular study actually had some findings of encephalitis. And then there was another study of 18 patients, only 6 with neurosyndrome. And those neuro symptoms were very, very, I would say, wishy-washy. I mean, you're looking at myalgia, headaches, and decreased taste. So maybe decreased taste being the biggest one. Headaches can be really from a lot of different things, and myalgias again from a lot of different things. But they showed absolutely no evidence of stroke, herniation, or olfactory bulb damage in these patients. And then looking at the microscopic examination, you're actually seeing acute hypoxic injury in these patients. So these patients, after they passed away, looking at their brains, they had mainly findings of just low oxygen levels for long periods of time. And that's a lot of times what you'll find in a lot of these COVID-19 patients. So I think going forward from here, when neuropath starts to pick up a little bit more, hopefully we will be able to look at what actually caused some of the neuropathological and clinical findings in some of these patients. This is kind of, this next graph is kind of looking into this larger study with 18 patients. And as you can see, everybody kind of had acute hypoxic ischemic damage, but no one really had that any of the other findings of encephalitis or anything like that. So I guess just in conclusion here, we're looking at that there's this increased incidence of hypercoagulability with severe COVID-19 disease. That's seen, and not only in the brain, but elsewhere throughout the body. And that's a common thing and a common theme. And that can definitely cause bleeds in the brain, that can cause strokes in the brain, that can cause clots in the brain, in both the veins and as well as the arteries. It seems to be hitting people that are slightly younger. There's also this increased risk of stroke, which is multifactorial as well. And there is suggestion in the literature now that COVID-19 may be affecting brain cells through direct neurotropism, but the actual effect is yet to be seen and to be proven. And I'll end there and I'll give some time for questions.
Thank you so much, Pravin. That was really good. And I think the first question I have, I think you mentioned some of it in the presentation, but what is the timeline of neurological manifestations? And is it before or after the classic sign of symptoms of COVID-19?
That's an awesome question. So looking at it, it appears that in most patients, there was a thought that it was occurring slowly after the initial respiratory type syndrome. What's starting to be noticed is that some patients are more resilient towards that respiratory syndrome, and some patients are actually presenting with those syndrome of hallucinations, presenting with this acute neurological deterioration of sorts, and this encephalopathy of sorts. And they're not 100% sure why that's occurring right from the get-go with very minimal other disease like respiratory disease and whatnot. The thought is that perhaps they have some immunity towards it from a respiratory standpoint, but that's yet to be seen as well. And obviously none of those patients, most of those patients get better, though that's a good side to it in general. And I think this study was done in Indiana recently, but they were looking at it, and of the patients that developed hallucinations and acute agitation as their primary syndrome, they healed within about 2 to 4 weeks. I think that was the median time to resolution of syndrome.
Yeah, awesome, Pravin. Thank you so much for that. I really appreciate this informative and insightful presentation. So if I may just had maybe ask another question or echo what Mark just asked you. So if a patient comes in 30 days after they've had, recovered from COVID, and now they're showing stroke-like symptoms, is it safe to assume that that stroke 30 days later could be related to the COVID-19 disease? Yeah,
that's a $1 million question. What I'm seeing more and more often, I think, with these cases is that some of these patients are persistently positive, and I'm not sure what to make of that. I don't know if you guys have seen that as well in your hospitals.
Most
But
definitely.
after 30 days, sometimes patients are still presenting positive. The other thing is that I would say I would check those other markers, looking at fibrinogen, D-dimer, looking at the pro-inflammatory markers to try and see if there is still some lingering, maybe it's not necessarily the infection itself, but perhaps it's the immune system still kind of overactive and causing some of that potential hypercoagulability. If that's still remaining, then I would say that it's more likely related to post-COVID-19 type of syndrome, maybe hypercoagulability from that. If everything kind of dropped back to normal, I would really look for other stroke causes. I mean, a lot of patients are still patients of, they still can have, atrial fibrillation and everything else.
Thank you for that.
Thank you, Pravin. I think as a follow-up to Wally's question, so we know in COVID-19, not only there's that hypercoagulable state, but also there's some platelet activation also. So assuming the patient came to the hospital and get treated for COVID-19, should we give that patient antiplatelet as primary prevention for ischemic stroke? Is that something that...
Do they present with any kind of neurological syndrome in this case?
Assuming they did not present, either they present with neurological symptom or not, because you're assuming that they hypercoagulable and some platelet activation, should that be part of the equation that we think about primary prevention for ischemic stroke, since we have seen so many cases where they were in the hospital and 30 days later they presented with some ischemic
with a stroke or so. That's a good one. I think for right now, just given the potential for bleeds with this, I think choosing either anticoagulation versus antiplatelet may be your best strategy. Just looking at the patients that have had hypercoagulable states, they usually do better with some kind of an anticoagulant, I think. Just kind of looking at the data there. I don't think we've seen enough patients out far enough from being on a single antiplatelet or dual antiplatelet with COVID-19. And I don't think anybody has looked at it head to head, especially between an anticoagulant versus single or dual antiplatelet medications. From stroke literature in itself, though, adding a antiplatelet or dual antiplatelet to anticoagulants for the reduction of stroke risk actually doesn't reduce the it reduces slightly the risk of stroke, but it also significantly increases your risk of bleed. So I wouldn't think that would be necessarily different in this population as well, and potentially putting them on both may increase that risk of bleed. But if you think that they are hypercoagulable as a result of the COVID-19, I would definitely go with the anticoagulant over the antiplatelet.
All right. So Pravin, so since we're talking about stroke, a recent study that was done at Cornell in New York showed that if you look at, all of the COVID cases that came to the emergency room and hospitalized in that, in that hospital system, about approximately 2% of them had ischemic stroke, right? So, I mean, this is New York, lots of patients, to 2%, that's a pretty significant number. Would you recommend maybe checking all suspected or confirmed cases of stroke for COVID-19?
I mean, at this point, I think it's not a bad idea, given the fact that there's a predilection for brain disease with it and the potential for hypercoagulability. A lot of patients are asymptomatic with COVID-19, especially if the patient's a younger patient, in their anywhere from 40s to 70s, I would say, if they were, or younger, if they were having strokes, and you don't have another cause per se, especially, you look in their neck, they don't have any carotid disease, you look at their heart, they don't have AFib. I think I would test them earlier than later for it, just to make sure that that's not something playing into this, because that could definitely cause strokes, obviously.
All right.
Yeah.
And so there's something you mentioned in the presentation that we're not exactly sure how COVID-19 actually crosses the blood-brain barrier or attack the neurologic cells. But would you say, from what we know at this point, that SARS-CoV-2 is a neuropathogen?
More and more evidence is seemingly showing that it can be. I don't know that, and I'm not 100% sure why it is attacking certain people a little bit worse, and why it is actually, because on some of these neuropathological stains, we're actually seeing areas of the brain actually very heavily affected. So it can affect the brain. It can get into those areas of the brain that have the ACE2 receptor. In some patients, though, in most patients, it's not neuroinvasive. It doesn't go in there, and it's not causing major brain issues. It's a small subset, and I don't know that we have a good characteristic of those patients and why it's entering some of these patients more so than others. It's possible that they have a higher receptor count of ACE2 there, but even that, that would be going a little far to assume, because just looking at neuropath staining, I'm sure that they tested for the ACE2 receptor as well as the RT-PCR.
All right. So Pravin, during your presentation, you did mention that CSF analysis specifically for SARS-CoV-2 hasn't really been all that great or yielding, right? So what about MRI EEG? For example, the Solomon study in the New England Journal with the 18 patients, they didn't actually do MRI EEG or CSF analysis, partly because these patients, are isolated, I suppose, right? So again, an MRI EEG is a little tedious. So how aggressive should we really be with, trying to get MRIs, EEGs with these patients outside of stroke patients?
Yeah. Well, that's what I was going to say. It depends on what the presentation is. If you're looking at encephalopathy and it's not a resolving encephalopathy, and you don't have a really good other case for why this is, I think starting off with an EEG to look for any kind of electrostructural type of damage, as well as potentially, if you have the ability to, getting an MRI, that may be helpful. But this is in those patients that they don't really have an alternative reason for their encephalopathy. I think that we have to utilize our resources appropriately, but as we're starting to understand more and more about the disease and getting more comfortable, I guess, with it, taking patients for MRIs, taking patients for EEG is becoming a bigger and bigger reality. So that's why we have more of these studies with neuropathologic findings, as well as neuroimaging findings and electro findings. I know currently we have I think it's a cohort of like 1,203 neurological patients that we're analyzing right now, just because we've had so many on EEG. I know that there's a neuro cohort throughout the country, and hopefully within the next few months, we'll have a lot more answers for this, but they're gathering together all of the EEG data between several of the large centers. They're also getting together with a lot of the neurological symptoms, as well as their neuroimaging findings, and they're trying to put it together using machine learning as well to try and figure out what exactly fits with what. So more to come, I think, within the next month or two, hopefully. But yeah, I'll definitely try and post it out there as soon as things are out.
Yeah, it looks like you're going to be coming back.
Thank you for mentioning that, because that was a question I had. I was thinking, like, is there a specific pattern of stroke distribution, or different what kind of patterns to look for in brain imaging when it comes to COVID-19? So I guess we don't have the answer for that yet, but you guys are
not as of yet. What we're seeing more often than others, especially in the younger population, is this large vessel occlusion stroke. So, I mean, their entire MCA, their entire right MCA, left MCA is just out, and they don't really have another cause for it. In certain populations, we're seeing these multifocal strokes that it look more like a showering. Maybe that's something that developed in the heart. But you know, just looking at it retrospectively, it's so hard to gather any kind of thing, because all of these studies have anywhere between 8 and 200 patients in them, and so and only like, I mean, even in the Chinese study, it was only 5% of them that had strokes, and that was like 5% of 200 patients. It's very hard to actually gather and make anything meaningful from something like that.
Pravin, we have a question from Facebook. So Yolet Ledger asks, so since you mentioned that most neurological problem resulted from hypoxia, is early intubation or the treatment of hypoxia itself help to prevent those neurological issues?
Some of my colleagues over in Chicago, I think, tried to answer that. They looked at this and just kind of in their cohort of patients, I think that they found that so looking at their brain imaging, there was findings of hypoxia, but the thing is that they never had any hypoxic, like their SATs never dropped below 90 at any point during their hospitalization. So I'm kind of wondering as to whether that has something to do with it, or if it's just this chronic hypoxia and just low SpO2 and FiO2 that's driving this. I've talked about this with some neurointensivists, and some of the thought was to potentially replace PbTO2 monitors, looking at the partial brain, tension, and trying to see if brain oxygenation is actually being affected in some of these encephalopathic patients. No one has done that yet, really just because of the risk with some of these patients to that potential aerosolization, I think. But looking at it, I mean, with PbTO2 monitoring, I mean, it's a hand drill a lot of the time, and you could wear potentially all of the air hoods and everything that you need to kind of do that. There's interest in potentially monitoring some of these patients, especially with chronic hypoxia, to see if there's an effect of the brain oxygenation there.
All right.
There's also there's also some technology looking at non-invasive monitoring as well for some of these patients. So
thanks for
hopefully,
that.
hopefully within the next few, there will be something there as well. But yeah,
we're learning as we go.
Yeah,
so
I mean, that's good. It seems like what it's been like with every body system in this, is that we're learning as we go with a lot of this.
So here's another question for you, Pravin, from Facebook. So Melanie asked, is it clear from the data if those treated with dexamethasone had higher or lower rates of neurological symptoms? So what's steroid doing here?
I love it. We are actually, in our cohort of patients, we have, like I said, that 1,200 patient population here. We had the because, and I don't know if this was the same at your institutions, but previously it was kind of like a no-no to use steroids in the beginning, and then all of a sudden in the middle, everybody was like, oh, we should use steroids. We want to take a look at the population prior and post, and we're actually, we threw that study out there. So we're gonna hopefully take a look at that within the next week or two. But that's one of the biggest questions that I have. Did this actually help, like therapy wise? Did dexamethasone actually help with the encephalopathy and the neurological features of these patients as well? I mean, it's getting people off vents sooner, but I mean, is it also getting people more clear, or is it because it's a steroid, it's making you a little bit more delirious? That's a great question.
Yeah, I think it probably dose related also, right? So
yeah, absolutely.
Yeah. Because I was really impressed by the recovery trial where they use a very, I mean, I'm not gonna say very small dose, but they use a small dose, 6 milligram for dexamethasone, and I think they're trying to mitigate those other negative aspect of steroids too when it comes to mental issues.
It's interesting. We've had a couple of patients that were post-neurosurgical in our ICU, obviously, and we have them on mega doses of dexamethasone, and then all of a sudden they will pop up positive with COVID-19, and we're kind of like, should we decrease the dose or keep it where it's at? Or so we've been keeping it where the dose is at for their neurosurgical issue. And they've actually done quite well. So I'm thinking that just kind of turning down the immune system for that using the steroids is probably the backing to it.
So I guess speaking of steroids, so those that have like maybe, you know, GBS, or they come in with, you know, acute disseminated encephalitis, so, you know, would you still give those guys like 1 gram of solomedrol daily, you know, such high doses, or should you just stick with your dexamethasone and call it a day?
We've had several cases. Like I said, I think I've treated 6 patients with GBS since COVID has started, which is in itself a very high number of GBS cases that I've seen for any kind of pathologic process. We've treated with the 1 gram of solumedrol for 5 days, followed by we did plasmapheresis afterwards on, I believe, 5 of them, and then we went straight to IVIG. And with all of them, they've had complete resolution of their syndrome. So that was actually pretty good. The other thing that I found quite interesting is that even though they had COVID-19 and they had GBS, their respiratory syndrome wasn't as bad in all 5 of those patients as their GBS. Their GBS really kind of played out more so than everything else, leading me to think that maybe COVID-19, they were probably asymptomatic from it, and even if it was something else that caused the GBS, because we tested all of them, we did a lumbar puncture on all of them. They had the cytoalbuminergic dissociation, but they all of them also tested negative for the RT-PCR for COVID-19 as well. So was there some kind of direct neuronal invasion? I don't think so. I mean, it sounds like it's just a response to either COVID-19 or something else. But it's kind of an interesting feature there that you know, it didn't really affect the neuronal tissue, or wasn't in the CSF at least. 2 of those patients actually suffered from acute paranoia and hallucinations. Again, I don't think it was related to the solumedrol. We did give them a dose of 1 gram, but the thing is that their encephalopathy actually, one of them actually had very vivid hallucinations, and this was only into like the 4th day of her plex. She hadn't had any with the solumedrol and hadn't had any with the previous dose of the plex either. But it was actually as she started to get better from everything, we actually extubated her, and then she told us about some of her hallucinations at that point.
Pravin, for people with neurological involvement, what's the recovery rate that you're seeing? And also, does neurological involvement carry any prognostic indication?
I would have to say that it's related to the neurological damage that's happened. For a lot of the patients that I've seen that have had anoxic brain injury or hypoxic brain injury, they've had protracted courses so far. Some of them are dead. Some of them are in long-term acute care facilities. I haven't seen very good outcomes with the anoxic and hypoxic brain injuries. Stroke from this, I've seen several in outpatient clinic follow-up, and they're doing quite well for the most of them, as long as they didn't have a massive stroke. No one was offered a hemicraniectomy, although the strokes that we saw with COVID weren't they weren't massive, or they were so massive that it was thought that a hemicraniectomy wouldn't necessarily improve their outcome, just because their functional outcome from such a stroke would be so bad. Several patients had large intracerebral hemorrhages, and then most of our intracerebral hemorrhages were these very small hypertensive, almost related bleeds. All of those that were less than 30 cc's did quite well. The larger bleeds, I think the family withdrew early on most of the time, but their ICH scores were in the 4 or 5 area. So they had probably greater than 95% mortality with just their bleed in itself. So looking at the outcomes, and then as far as the ones with seizures, surprisingly, it was very easy to treat a lot of them. They would have several seizures found on EEG or clinical, and I think on each one of them, we just treated them with levetiracetam, and it kind of knocked out all of their seizures. And it was just a single AED. It wasn't like multiple AEDs, reverse drip, and all that stuff. It didn't have to go that bad. So that was good. And like I said, with the GBS patients, all of them made a full recovery. So that was a good thing.
All right. So Pravin, you know, from what you've looked at so far, or maybe even from your own experience in the ICU, are there any like identifiable risk factors in some of these patients with neurological manifestations?
I haven't seen anything outside of the normal, you know, the things that make you prone to becoming severe, namely the obesity, pregnancy, and elderly age. But those also kind of lead you to higher stroke risk factors, higher hypertensive bleed risk factors, and of course, higher dementia and delirium risk factors. So those being tied together, it's a little bit harder to recognize it. But the patients, I think the thing that surprised me most was the obesity. The obesity is kind of like on the higher level of making people push into that severe category, and I think that's both respiratory as well as with the brain. So that's the only thing that I've seen, in at least anecdotally in my patient population.
Let's see. I don't see any more Facebook questions. I think
I'm
not sure what
more actually. Maybe I'll just put Pravin on the spot a little bit here.
Yeah.
Maybe you can predict the future.
Maybe. No, probably not.
So where are you? How convinced are you about the theory of direct viral invasion? You know, maybe on a scale of 1 to 10, that how convinced are you so far that
the virus is actually causing some problems?
Yeah.
I think in certain population, in certain people, it is. It absolutely, especially, I mean, given some of these pathologic findings, I think in the neuropath studies that they didn't really see any kind of neuronal invasion. Those patients did not have severe or any kind of neuronal type of issues. And I think most of them died from anoxic or hypoxic brain injury. But I think in certain people that are having, and again, the strokes and the bleeds, I don't necessarily think those are related also to COVID-19. I think that's more related to just an overall hypercoagulable state. But there are certain people that I think if you were to take a sample of their brain, and this may happen when they die naturally or whatnot, if they have improved from this, you may start to see some of those things, especially these patients that are starting to show this encephalopathy. It's almost like a long-standing delirium, almost, and in I think where was he from? I think one of the docs from Columbia was actually saying that, and one from Hopkins actually was saying that it looks like this may be more related to like a breakdown of brain tissue in some of the areas, and it's coming to look a little bit more like an Alzheimer's type of picture. So that's what I'm wondering about. I mean, I don't think we've sent tau proteins and all of that. I'm just assuming that we're thinking a lot of that stuff may be just neuronal inflammation. It'll be non-specific, that kind of thing. But it may not hurt to take a look at some of these things in future studies, or if we send CSF, just to check that out on patients that are having these delirious and dementia type syndrome.
Thank you so much, Pravin. I think that was very informative, and I think we probably can have you back because there's a lot of things that you are looking at the Cleveland Clinic and other people looking at around the country. But
Absolutely.
to finish, I would like to ask you, what is your take-home message from a neurologist standpoint?
From a neurologist standpoint, I think focusing on really staying away from the hypoxic side of things. I think pathological findings are suggesting, especially with the brain pathology, that these patients, may be silently hypoxic for longer than they may play out. I think a lot of patients with COVID-19 are probably hypoxic at home and they don't know about it until they start to get some of these syndromes and some of these symptoms. Treating early, I think with the steroids, treating early with whatever medication turns out to work out for COVID-19 should be employed for these, especially when it comes to a respiratory type of thing, because if you don't feed the brain, then all of a sudden you're going to start to have a lot of these neuropathologic findings. The second thing is especially in some of these severe cases, making sure that we're getting on top of the hypercoagulable type of findings. We are being a lot more accepting of these patients and giving them TPA. In the beginning, there was a big question as to, is TPA, should it be contraindicated? Should we use it? Like what happens in these patients? We're doing endovascular procedures on these patients as well, if they're suffering from acute ischemic stroke as well. So I think outcomes are going to get better as long as we are more comfortable with disease, more comfortable with the disease process. But, just treating the patients with, the best science that we know, I think is going to be the most important take home for all of us.
Thank you so much, Pravin. And actually, because you were talking about hypoxia just now, I just saw a question from Tim on Facebook. He had asked about hypoxia tolerance. So I guess what he's getting at is, why is it that a lot of these patients are not confused, even though they're sitting at 78% and they're talking to you, right? What's going on? The brain develops some resilience, or what's going on there?
That's a really interesting thing, because I thought maybe, and I saw this firsthand when I went to New York. There were patients in the rooms where their SATs were in the 60s and 70s, and I thought, maybe there's some kind of issue with the pulse ox first, and then I thought maybe there's and then but after a while you start seeing this with all the patients, and you're like, no, probably not. Then you get an ABG, and their PaO2 is really actually low. It's hard to know. I haven't gotten to the base of that, other than there's probably enough brain tissue that's getting just enough oxygen so that people don't have clinical syndrome or clinical symptoms. Maybe some of the older population or population that has dementia baseline or something like that may feel some of those syndrome or symptoms sooner. But that's been a cloud over my head. I mean, and these patients are ventilating well. I mean, their CO2 is relatively normal, which is again usually the driver of a lot of encephalopathy when CO2 starts to pick up and you start to get that CO2 narcosis. This is one of these first diseases where you're starting to see this very, very subacute type of hypoxia. And, I mean, we don't know how long they sat in this, 80s, maybe, maybe it's a slow drop over that week before they come into the hospital with more of a severe lung disease, that they're just having, they're having lower SATs, and then, finally they come in. But that's I haven't been able to answer that one. That's a tough one.
Thank you for that.
No, of course.
Well, I don't see any other question here on Facebook. So I think that brings us to the end of today's lecture. We certainly appreciate you immensely, Pravin. And like Mark and I said before, we would certainly love to have you back here. And Pravin, I'm pretty sure
hope we have some more.
Oh yeah, certainly. And people can find you on Facebook and on social media, I suppose. Yeah, if they have questions.
Yeah, absolutely.
Yeah. Okay.
Feel free at any point. But thank you guys for having me. This was a great opportunity.
No, we appreciate you. Thank you so much. And
that brings us to.
that brings us to the end of today's lecture, and we will certainly be back probably in another 2 weeks. So thank you so much for tuning in, and see you next time.
Thank you.
Thanks again.